Hello and welcome. My name is Nancy Berry. I am the Marketing Manager for Rosewood Centers for Eating Disorders and your host for the Rosewood Institute's webinar series, Binge Eating Disorders and Adolescents. Joining me in the studio today is Dr. Dena Cabrera, Director of the Rosewood Institute, and Kim Vavrosky, Registered Dietitian and Certified Diabetes Educator at our Adolescent Program. Welcome, Dr. Cabrera and Kim.
Thank you, Nancy. We welcome you today and thank you for joining us. This is Dena Cabrera and I will get us started today. We have a short time, 30 minutes, so we're going to cram a lot of information in a short amount of time. I will begin with the outline here. We're going to forward this ahead here. The first thing I would like to review with you is the proposed DSM-5 diagnosis for binge eating disorder, particularly related to children and teens. Then we will review risk factors for binge eating disorder. Also, nutritional assessment and interventions, and I'll turn it over to Kim for that, as well as therapeutic interventions. So as we all know, DSM-4 has listed binge eating disorder in the back of the book as a research criteria. It does list diagnostic criteria or symptoms, but it is not a disorder as it stands on its own. It is under eating disorder not otherwise specified, which is actually a real problem. And fortunately for the DSM-5, it will become and recognized as an eating disorder, as its own category under binge eating disorder. And hopefully insurances will also note that it is a mental illness, it is an issue, and it should be under its own category of the eating disorder. It is the most prevalent eating disorder out of all the eating disorders. And so this is the proposed binge eating disorder for DSM-5, particularly related to children and teens, which comes out of the Eating Disorder Recovery Today. Research has been done at Western Psychiatric Institute, and it was published back in 2009 looking at these specific criteria. The criteria listed here is a pattern of recurrent episodes of binge eating disorder, and the duration has not been established yet, but it is characterized by both of the following: food seeking and absence of hunger, and a sense of lack of control over eating. I think that that is something to differentiate between the adult criteria. One of the criteria is eating a large amount of food in a short amount of time, and particularly related to children and teens, that may not be present. It's more important to look at the loss of control over eating, and that's something that we've also seen in our center as well. The other B is category binge eating disorder associated with one or more of the following. So one of these three would be either food seeking in response to negative emotions, such as sadness, boredom, or restlessness, food seeking as a reward, or food seeking or hiding food. And that's something that we very common see is, because of the urges to binge, they will hide food, and because of the shame, they don't acknowledge that, really oftentimes to themselves that they're doing this. And C, symptoms persist over a period of at least 3 months. So that pretty much remains the same. We're going to advance forward here somehow. There we go. Okay. Researchers are still trying to determine what specific risk factors would or could potentially result in binge eating disorder. These are the some that are based on research, but also anecdotally that we've come together. There's the biological and genetic vulnerability to weight-related issues. Also looking at adverse childhood experiences, just repeated exposure to negative comments, bullying about weight, shape, or eating. Also, which is really significant and has been identified in the research, body dissatisfaction, which can lead to depression. And the two coupled together is the strongest risk factor for the use of unhealthy and weight control behaviors. And then other psychological or sociocultural issues such as trauma, socioeconomic struggles or lack of resources, and comorbid issues, self-injurious behavior, substance abuse, depression, anxiety, PTSD, and so on. Okay, I'm going to go ahead and turn it over to Kim.
Thank you. Despite many binge eaters being overweight, it is possible for a binge eater to be malnourished. Malnutrition is a condition where the body is not receiving the amount of vitamins or other nutrients it needs to maintain its organ function and healthy tissue function. So a person could be binge eating on non-nutrient-filled foods, therefore getting the calories to be gaining weight, however be malnourished in those vitamins that their body requires. Some people, depending on the person, it could be a long or short period of time for that malnutrition. The amount of treatment needed to fix that, it's going to depend on how much damage was done and the severity of it. People who are chronically malnourished may need extra medical attention to have that happen. Just like anybody else with an eating disorder, binge eating disorders with the malnutrition, it is similar to the anorexia, to the bulimia. You're going to see the medical complications of the fatigue, of the muscle loss, of the decreased muscle tone, the weakness, the difficulty with the energy and the fuzzy thinking, not being able to process things as quickly. You're going to see the hair loss. You're going to see the brittle bones and nails, dental problems, scaly skin, potential kidney infections, heart infections, dehydration. This is all possible despite somebody being a binge eater, simply because they're not getting the actual nutrients that they need. Of course, with all of these potential risk factors, the ultimate risk factor would be death. As a dietitian working with a binge eater, one of the most important things that we can work on, or one of the most key things to be addressing right away, is going to be building a rapport and building that trust with that person. Weight is probably something they've struggled with for most of their life, and to have somebody tell you what you can and can't eat in their mind is going to be very scary. They're not going to want to gain weight, so they're going to have to build that rapport and trust with that dietitian first. We're going to start doing that by doing a complete and full assessment, really starting to look at what their goals are. Dietitian's goals might not be in line with the patient's goals, and if you're trying to push them for a goal that's not there, it's just not going to be very realistic to follow. We definitely need to have a discussion on the recovery goals, also looking at their current routines, the intake that they have. Do they sleep in? Do they skip breakfast? Do they skip lunch because they're too busy at work? What kind of rituals do they follow? So getting a very, very clear picture of their day-to-day life. Also working with the dietitian, you need to address the different food myths that you hear. They're all over in society. They're in newspapers, they're on TV, the radio. So being able to teach somebody how to play detective and identify what is correct and what might not be as accurate as it's being perceived. At the same time, you need to be balancing the small successes for that goal. That nutrition long-time goal is going to be that long-term goal. You need to set the tiny little smaller successes and goals along the way and make sure that those are being rewarded to help with the motivation to continue with the dietary, the lifestyle changes that are being made. In that initial nutrition assessment, first of all, I want to find out why they're looking for treatment. Are they here because they want to be, or are they here because doctor is saying that they have to? That's just going to speak towards their level of motivation and where they're at in the potential stages of change and what lifestyle changes they may be willing to alter for this. It's very important to get an idea of their weight history and the immediate family history. As we all know, weight is somewhat genetic. It's not completely, but knowing that genetic history can at least give you an idea of what's going to be a realistic or a semi-realistic goal for that individual. Being an adolescent, that family support is going to be absolutely key. Most adolescents do not have access to getting to the grocery store, getting that food and meal support. So it's going to be up to the parents, to the aunts, to the uncles, whoever is in the house to provide those products for that adolescent. At the same time, the whole family needs to, quote unquote, buy into the model of mindful eating, of not having good foods and bad foods. If we have one person in the house that's trying to do that but hearing messages from other people in the house saying opposite, it can be very difficult for that adolescent with that binge eating who's going to treatment. Looking at the diet history is going to be essential also. Knowing that they've tried diets X, Y, and Z and loved this part and hated that part would allow the dietitian to tailor their current nutrition plan for what did and didn't work for them. Also looking at different medications. Some medications that people, or especially adolescents, might be on could affect weight, causing more weight gain. Antidepressants would go with this also. Lots of binge eating adolescents or binge eaters in general might be on antidepressants, and that could be affecting weight to a point. Obviously, medical and physical concerns. Depending on the weight status of the individual, they might need to have some medical clearance, make sure that they are physically safe to be out doing activities. As you know, the best way to get that activity is to go out and raise your heart rate, but we want to make sure that that is safe to be doing. Evaluating of eating disorder behaviors. Lots of times teens don't recognize that they're engaging in the behavior. It's a habit. It's something that my family's always done, etc., etc. And that might be so. However, it's going to come down to the frame of mind behind that behavior and if it has to be done and why it has to be done. We also want to look at what a good and bad day for food recall is. I know what a good day of eating is. I don't want them to just simply recall that to me. I want to know what a good day is for them. A good day could be eating 3 meals, or a good day could be binging only one time compared to a bad day. So that's going to give me an idea of their daily life. Of course, as with anybody else, we want to be aware of food allergies, intolerances, dislikes, fears. Keeping in mind that a lot of the adolescents haven't been exposed to different varieties of food, so dislikes can be something to be worked with. Reintroducing foods is going to be key to expanding their taste palette. Trying 2 or 3 new foods a week. Our taste buds change over time, so the more you introduce different foods, the more you might find you like. Something you didn't like 2 months ago, you might like again. Also identifying if there's a food fear around it. If they're afraid of pizza, why are they afraid of pizza? Well, it's because they binge every time they eat it. Okay, well, that's a normal food for an adolescent to be eating, so we need to work around those fears and learn to re-normalize that food. We also need to look at how the eating disorders affected their relationships with school, with work. Are they avoiding people? Do they sit by themselves in a corner at school so they're isolating? They're not interacting with other people their age. Is it affecting work at all? Even relationships at home. Are they hiding in their room at mealtime so they don't have to be seen eating with the family? So it's just the social interactions of it. Other things to keep in mind for adolescents is going to be newer eating disorders. These are not actually DSM eating disorders, but they are publicly stated as eating disorders, and those are going to be orthorexia, which would be eating all or only organic foods, diabulimia, that's going to be somebody who is diabetic and adjusting their insulin to control their weight, and drunkorexia. That's going to be one where you don't eat all day and you literally drink your calories and alcohol. Based on all this information, of course, looking at the family history and the individual, we use the height and weight for the evaluations of the meal plan. We got to start at a standard place and then make adjustments for that individual. Everything needs to be individualized for that specific person. As a clinical team, this would go for the family also. It's different things to keep in mind as you're working with this adolescent. Are they wearing the same clothing? Are they wearing different clothing? Are they always wearing the same sweatshirt because that's the only one that fits? Are they avoiding wearing specific clothes because they think it makes them look heavier, etc., etc.? Are they hiding behind unhealthy habits such as poor hygiene and not changing clothes like they should be? The clinical team is going to be keeping track of any weight loss or weight gain of 3 pounds or more. It should be done doing blind weights. It's of course important to let the adolescent know that they are making progress in the correct direction. For some individuals, it might be beneficial for them to know the weight, for others not, so that's going to have to be a clinical team judgment call. Other things to watch out for is going to be any puffiness in the face or stomach. That could be a sign of other eating disorder behaviors that are happening or water retention. Things that could lead to, things that indicate depression could be isolating, self-harm, cross-addictions. Any of these things could be depression going with that eating disorder. So isolating, not going near others, self-harming, a way of releasing pain, of showing an outward sign of the pain that they're feeling, cross-addiction such as substances, alcohol, drug use, whatever it might be. Impulse changes in appearance and lifestyle. Are they somebody who had always been very neat and all of a sudden their room is a complete mess? So just those sudden changes. Emotional fluctuations. Are they going from one end of the spectrum to the other very, very quickly? Hard to keep track of what mood they're going to be in. You feel like you're walking down eggshells. And something else to look out for is going to be gum use or water loading. Those are used a lot in eating disorders. Gum use gives you that sensation of chewing, but you're not actually chewing or getting the calories from it. Water loading is going to fill a person up so they don't have the growling stomach, except you're not getting the calories. So those are all going to be potential signs of further eating disorder, things that need to be addressed. So as we're working on these nutritional goals, we want to work with the continued weight loss and while challenging the different types of food, the dislikes, the fears, adding in new varieties as we go, looking at decreasing the eating disorder behaviors, whatever we've determined those are, keeping an accurate food tracking. Basically that comes down to being honest with what you're doing. Those bites, licks, and tastes do count along the way, especially if they're constant. So just being aware and accountable of what those are. Doing weekly food and nutrition challenges. It's very, very easy when somebody has an eating disorder to do a cross disorder or to switch addictions. So we want to make sure that as we're working on challenging the binge eating, that somebody doesn't turn to having more bulimic or anorexic traits. So doing food challenges is going to help prevent that, in that you're introducing, say, desserts twice a week, or you're challenging them going to a fast food outing once a week. So you're normalizing those foods. Not that they can't have it. Yes, they're a little bit overweight. Yes, we're working on it, but it is normal to eat those foods. So let's find a way that they can fit those foods into their normal life and still be meeting their nutrition goals. Making sure that family is supportive, like I mentioned earlier. If everybody in the house is not on the same page, it's just going to be that much harder for that adolescent. Acknowledging those small victories, setting those little goals, and having prizes awaiting for them, preferably non-food prizes. And then, again, continuing that trust and communication between the team and the family.
Great, thank you. So in turning back over to the psychological aspects or the treatment approach, as you can see, as Kim was talking, much of the nutritional therapy and the counseling aspect of treating binge eating disorder overlaps quite a bit. I could sit here and because of our limited time, I'm not going to go through the treatment approach that has, so to speak, been evidence-based for binge eating, particularly CBT. or even talk about DBT, as we know that that's been very effective. But I really want to focus on working with the families, particularly because I have noticed that when treating binge eating disorder with children and adolescents, it is essential that, as Kim said earlier, that we get the family on board, that we get the whole environment that they're engaged in on board so that they can have the best possibility at recovery. So I want to talk about, as I've been working with adolescents and working with families, I've realized just how much education is essential to the treatment of BED. I really feel that this is something that is becoming more available, and through the Binge Eating Disorder Association, I really see that as a powerful resource for families. But families have a long ways to go in learning how to help their child who is struggling with weight-related issues. So this is what I wanted to focus on. How do you create that healthy or balanced environment? Some families don't even realize what their impact is in the messages that they're sending to their teens. So literally, as therapists or counselors, sitting down and talking to them about how do you solve problems as it resolves around getting more exercise or a meal plan, helping them to watch their own behaviors about eating, drinking, drug use, or handling stress. We have a family meal with the parents who come in to visit their children in treatment. It is amazing how often we hear, remarks about the food, like, "Oh my gosh, this is so much food," or "How do you eat this much?" and I couldn't eat all this. And so we really have to do some education about how we want to refrain from those remarks. And so doing that assessment in the family is going to be critical. So teaching them to monitor their own talk about their own body and bodies of others. So they're looking at their weight prejudice, challenging beliefs about thinness, their attitudes toward body image or exercise, dieting, helping them to understand or recognize their limited physical activity, and encouraging, what does that look like? In our cultural, we have a definition of what health looks like, and it's very narrow, so helping them broaden that definition and get them out doing things as a family that will get them physically active, as well as looking at computers in their time being sedentary. We also, again, Kim mentioned it, I just want to re-emphasize that even as a counselor, this is so important because families, patients, they just don't get the no dieting or the non-dieting approach. It very much is critical in the treatment to binge eating disorder because we know that it can really set them up if they go into this dieting approach. It is a setup for failure, and research constantly validates that and supports that, helping them to just really understand what balance, variety, moderation is. I love to share this study with parents. It's coaching parents and really understanding that their time spent with families at meals, and this is where it's critical that they have, a family meal together. In this day and age with our fast-paced society and kids doing, 25 different things, and we're driving everywhere, it's hard to sit down as a family. I get that. So working with the family within their culture on how can we make this a possibility, because research shows that it's more related to psychological and academic success of pre-adolescents and adolescents than anything else, basically, than time spent in school, studying, church. That's how powerful the meals are. So we really want to emphasize that. Also, we want to help the family, not just the kids, promote body esteem. And I love working with mom and dad on challenging them about their attitudes towards shapes and sizes and what their skewed definition is of what healthy is. We had a family most recently that we were really challenging, and we come from a health at every size perspective, really looking at what that constitutes for them. And it was very narrow, and it was really seen, the rigidity was very evident in their child's behavior. So it's important to help them talk about the normative body changes, emphasize function over form. All this seems obvious, and in this field I think we think that everybody thinks this way, but I think it's extremely important to give this education, show that advertisements lie. And then, Kathy Cater just wrote this wonderful article about how we can truly help them nurture their body with compassion. And we know that the research shows that the more people feel aversive about their bodies, the less likely they're going to be able to take care of them. So really helping them understand that. That's something that we see with our patients who have binge eating disorder, the incredible shame related to their weight and their inability to really care for them. Oftentimes in treatment, we're actually setting a schedule up for them to just have good hygiene, practice hygiene. And so that's sometimes where we have to go, and that's where we have to be encouraging in the home. So I already kind of talked about this, but this is a real critical problem, particularly with binge eating. I don't think there's one patient I've seen who has binge eating disorder who hasn't been bullied or teased in some way. So really helping them develop those coping skills and teaching them resilience, how to shrug it off sometimes, how to speak their voice and convey what they mean and want, but then also how to throw others off, perhaps with humor. Overall self-esteem, just little tips, helping them develop their special talents. Sometimes what I've been impressed at is they come into treatment and it's the first time they've really felt accepted and validated, and that's usually because they're in an environment that everybody gets each other and understands each other. So really helping the family validate them and understand them and set them apart from their weight, shape, and attitude, that they're a real person. So we're running short, but I really wanted to emphasize this today, that binge eating disorder and shame are so highly correlated. Some of the interventions that we do from a therapeutic standpoint that I have found so remarkable and impactful into this into the treatment is narrative therapy, having them tell their life story. This is when you really get the group to help accept them and validate them. Writing a letter to their bully, writing a letter to their disorder, doing their first step as it relates to the 12 steps. We've done psychodrama, we do psychodrama here in our treatment center, and you don't have to be, it's important to be trained and certified in the area, but there's little things that you can do, like empty chair work and just addressing the disorder or addressing the bullies, but helping them create a picture on how to distinguish themselves and set themselves apart from their eating disorder, but also to diminish or reduce the shame in their lives. We do a lot of coping skills. We have 911 cards to help them when they're feeling overwhelmed and in a crisis. And we also have them fill out their own affirmation cards to remind them of how important and special they are. One of the biggest skills that we do within the context of family therapy is teaching parents to validate their children. And again, reinforcing that their bodies are going to do what they want if they get structure and balance in food, but to really start looking past their eating disorder. And then teaching them boundaries. I have found just anecdotally through the treatment of children and adolescents with this disorder that the boundaries are an issue. They also seem to have difficulties accepting their disorder and want to deflect and identify more with like substance issues or other issues related to their struggles rather than really accepting the eating disorder itself. And again, that goes back to the shame. So that's where we are. I encourage you to please, if you have any questions, to please email Sylvia, and I'm going to turn it back over to Nancy. It has been a pleasure. I hope that we gave you some nuggets of information in this short amount of time.
Thank you, Dr. Cabrera and Kim. We appreciate your time today. I'd also like to thank our listeners for taking time out of your busy schedule and want to just let you know of an exciting change starting next year, which is January 2013. We will move to 1-hour webinars and will include 1 CE provided for all of our listeners. So thank you again for joining us, and we hope you have a great day.